Thank you for the invite. Thank you, Dr. Penniston and the Rock Society. It's a great pleasure to be here and talk to you today about our experience in London of what we've done to try and improve the lives of these patients. These are my disclosures. I've included some historical ones just because those potentially are relevant, although those are about 4 or 5 years old. I thought I'd just start showing where I work. I like starting talks like this. So this is Guy's Hospital here. It was the largest hospital tower in the world. Somewhere else beat it. It's dwarfed by the Shard Tower Bridge in the background. And St Thomas's, where I was born and did a lot of my medical training here opposite the Houses of Parliament. So it's a very nice place to work. And history is important. I know why this isn't working. Yeah. And so, just to mention the original Cystine stone, it was described in 1810. At the time it was called cystic oxide because they mistakenly thought there was an oxide group. But they did make some correct observations. They said it was probably very rare, true. They said it was yellowish, semi-translucent, with peculiar sort of glistening luster, true. And they said they were unable to describe the unique smell it gives off when burning, and of course all the surgeons in the room know that to be true. This is from the book, this picture here, of the original stone, and this is the actual stone which is in the Gordon Museum at Guy's Hospital, where I work, and a few of you who've been over to London have visited that. And if no one believes us that that's the original stone, the group this was published in the BMJ in the 1960s, took a little sample of that stone to confirm that it was 100% cystine. So, we often hear these things said, I think. They are non-compliant with treatment, they're not compliant with follow-up. But in our unit, there's always this challenge back to us, actually. Who is being non-compliant with who? Is it the poor patient who's sort of grown up through childhood, through teenage years and adolescence to adulthood, being accused of faking it, attention-seeking and drug-seeking? Or is it the hospital, which is usually fairly rigid in the way that it is set up and designed to cater for the masses, not for the rare few? So these are sort of slides we normally show in talks I do on cystic uro, and you'd be pleased or not pleased maybe to know that I'm not going to talk about any of this today. What I'm going to talk about is that it's a rare disease, it's lonely. Patients have often never met another patient with a condition, and actually they know more than the doctors. They go into the emergency department, and actually the doctors never even heard of the condition, yet they try and pretend they do. School is a problem, transitioning is a problem, patients have difficulty with their studies or keeping employment, they have concerns about pregnancy and what that might mean, and there is relatively little peer-to-peer support and good information. And I like this slide because it just encapsulates some of the challenges we face in cystic uro. This is one of my patients here. She's in her mid-40s, and you can see she's had bilateral open surgery as a child, and you can try and count the number of scars from the perks that she's had. It's somewhere around about 18 or 20. Teopronin works. She takes teopronin, she doesn't form stones at all. She's had 4 children. Every time she stops it, she needs bilateral PCNLs again. Renal impairment is common in these patients. In our series, 3/4 have some degree of renal impairment, and hypertension is also very common. Stents in cross quickly, and this was a picture I took very recently of a stent that had been in for 16 days. You can see that it started being crossed already. So it is really important that these patients get timely surgery. And this is where it all started for me. It was interesting looking back at this. I found this poster from 2003, so I guess I was probably a very junior resident at the time. And I looked up, and I did a little thing, I presented this at the EAU on our experience with cystic uro, and we had 21 patients. This is almost like the benchmark of where it started for us. And I'd say that this is the previous cystic uro patient experience and a fairly typical patient experience. They manage the nephrology clinic, they may or may not have a separate urology clinic as well. They get a separate appointment to come back for imaging, and probably another appointment to come back for those results. If they found a stone, then they're put back into another clinic to come and talk about it, and they're not necessarily managed in a specialised stone unit. In the emergency setting, they're in and out of the emergency department, maybe get an opinion from the urology on call, but they're managed in exactly the same way as any other chronic patient. So there is this problem with fragmented care. They naturally get delays to surgery, and I'd say they have difficulty accessing the system. The medications, as you know, are really difficult, and our patients have a lot of trouble with this. And then they get labelled as non-compliant because of all these problems that are surrounding them. And I'm just going to go off on a tangent just for a minute, because I did a little bit of reading up about non-compliant behaviour. And actually, when you look at the causes of non-compliant behaviour, I think you recognise a lot of these features as causes in our patients. So communication, a lot of our patients, English is not their first language, a lot of them are from consanguineous families. There's an element of denial. They're 21, they want to go out with their friends, drink beer, eat burgers. Why is it happening to me? I'm not going to do this. A lot of patients do get secondary depression from the fact that they can't keep down work. And I don't think we can't really imagine the psychosocial stress that goes on with a lot of our patients trying to manage all of this. So I'm going to credit Kay Thomas here, my colleague from Guy. She's my senior urology colleague, who set this clinic up in 2008. I joined 2 years later. And the aim was to try and co-design a new experience for these patients. And we asked the patients what they wanted. So we used a focus group and a questionnaire to try and redesign our services. And so the Guy's Cystine Uro clinic was then born, and the first clinic occurred on the 1st of August 2008. It occurs twice monthly, it still does, and we only see Cystine Uro patients in that clinic. And it's growing rapidly, so the thing about those 21 I showed you in 2003, we've now had over 280 patients referred to our service. So the principles are, we get a joint urology and nephrology consultation, usually in the same clinic room. We get in-clinic ultrasound by a uroradiologist, so not a radiographer, radiologist, and we've had the same run with the radiologist for the last 17 years. Sadly, he's about to retire, and when he is away, we definitely notice the dropping quality of the ultrasounds that you get. We get in-clinic review by our specialist dietitian. We have renal pharmacy support to try and help with the medications, and we have a specialist nurse as well. And we wanted to rebrand and create a new website in the UK for our patients, which is obviously gone back now to 2010. And underpinning all of this in clinic, everybody gets genetic testing. We know this isn't required for diagnosis or treatment at the moment, but we have genotyped all our patients. Every patient does a pH diary prior to their appointment and brings that with them. We collect urines in clinic for amino acids and cytology looking for crystal urea. All patients get registered into a rare renal database, which is a national nephrology database for rare renal conditions. Everyone gets a card, I'll show you this later, in their wallet. And we try and offer surgery within 2 weeks of seeing them. That is very aspirational and it can be very difficult to achieve, but we still try and set out to try and offer that. And then we rebrand as well. So the brand sort of Cystine Uro UK, you may have seen the websites that we created in 2010. You create a brand and patients come to you. So the bits maybe we know, so patients of course need lifelong follow-up. So we see patients every 3 and 12 months depending on disease activity. Importantly, we use ultrasound first line, and I know this is different from a lot of units, but everyone gets an ultrasound, and we never book a CT, we just get a CT scan if there's clinical suspicion to do so or concern on the ultrasound scan. And we've had a number of patients who come from abroad, or patients who've seen us and then moved abroad. USA was in this list, we had a patient who moved to California, but they've now just moved to Portugal, so that's dropped off the list of where we have patients around the world. This is slightly old data that we published before, but unfortunately that delay in diagnosis stat is still true, that up to 25% of patients experience a delay in diagnosis, and if they do experience a delay, the mean was 7.5 years. That's 7.5 years when you could have made a diagnosis just in your earlier if the referring specialist had thought about it, sent a stone for analysis on a metabolic screen, etc. Medical management, I suppose, is well known to us, but important, the thing that may be different for us is trying to offer bespoke dietary advice through our specialist dietitian. About three quarters, 70% are on alkalization, and this is all based on pH diaries, and somewhere between 20 and 30% are currently taking a chelating agent. And we use a combination of tiopronin and penicillamine. Both drugs are difficult to get hold of in the UK. Tiopronin isn't licensed and is very expensive, which is why sometimes we prefer penicillamine. We've looked at our dietary outcomes, and of course, and our dietitian goes through obviously how to try and get more fluid into their diet, reducing salt and making sure you get adequate protein, reducing methionine, making sure you get adequate protein. And when we looked at these results, and we've re-altered this since, we've shown that our patients have made significant alterations to their diet as a result of this clinic. I mentioned the pH diary, and we use a target pH of 7.5 to 8. I know some guidelines might say slightly lower than 7 to 7.5. and we preferentially use potassium citrate. We have a problem with citrate in the UK. There aren't that many different alkalization preparations. The standard one patients get is liquid. Primary care physicians are very happy to give the liquid. It tastes disgusting and nobody takes it, but it's cheap. Effercitrate is an effervescent form which is more expensive, and actually they can prescribe that, and we're sort of getting there with that. And then Uracid K, the tablet form, isn't even licensed in the UK, so we probably have about 2 patients on it, because it's very, very hard to prescribe and more money. These are the type of pH, so this is the pH diary we typically ask patients to complete, and we ask them just to do a urine at random times, once a day at just different times. And this patient's done that very nicely here, just almost every 2 hours on a different day. But sometimes patients come in with a little bit of scrawl of paper. And this is one of my favourite patients who did this digital pH diary. They presented in their mid-30s with a staghorn stone here. They had a normal other kidney, you can't see it here, but they have a normal other kidney. And a PCNL found to have 100% cystine. Then he went away, bought a digital pH meter, and he tested his urine every single time he peed for 3 months and recorded them here. We've got a little graph plot here. And he spoke at our patient day about this and found all the different correlations that he found. So he's now 10 years out from his surgery. He has never taken any medication for cystinuria. He manages his alkalization himself. Yes, Fatty says he doesn't even test it much anymore because he knows what he's doing. He knows if he has a steak, it goes down a bit, and he drinks more water accordingly. He's a very good speaker at our patient days. And so we now more and more recommend that patients might want to buy a digital pH meter. It's so easy off Amazon. And so we got a medical student just to do a little project. Does it matter which pH meter you use? So we bought one for £10, one for £30, one for £100, used some dipsticks and some litmus paper and compared them to a sort of lab standard pH meter, and really found that they were very accurate and actually didn't really need much calibration. And although there was a little bit of drift with time, actually that makes very little difference when you're just comparing it to dipstick and trying to read something which the patients are not very good at. Chelating agents, of course the drugs work, we know the drugs work. I showed that in my patient earlier, and this is some of our data that showed the reduction in stone episodes, etc. But we know the problem is tolerability, and this is French data here that I've just put on here, showing that up to 1/3 of patients experience side effects and have to stop because of the medication. The funding issues in the UK are problematic. I know you have different funding issues here, because funding goes through primary care, and primary care won't prescribe this. All 280 patients, all the prescribing falls largely upon us because their referring units won't do it. And then we also suffered various different shortages in supply. We did look at what happens if you do get a side effect, so this is our data, very similar to that French data, isn't it, in terms of discontinuation, so around about 1/3, maybe tiopronin is a little bit better than penicillamine, but we still find penicillamine quite a useful drug. So if you do stop it and you cross over, so one option is to restart the same drug, just on a lower dose and build it up again. But actually we found that in nearly 60% of patients you can cross over to the other drug and they are able to take it. So that's a useful sort of tip to try if we get reactions in our patients. I'm not sure I need to tell this audience much about blood pressure management, but this has been really important. I'm trying to educate our patients and really encourage them to self-help, get a blood pressure machine, test it yourself, because it is such a common problem, and half our patients in our clinic have hypertension. And this graph, actually, I realise doesn't show the numbers on it, but it isn't just the older patients, it's the younger patients as well. And I put this slide in when I'm teaching our residents and just say, if our nephrologist is away, even a urologist can check our blood pressure. It's not difficult. We might have to ask advice on what to do, but we can still check our blood pressure. This isn't really a surgical talk, but just a few comments about surgery. We do use lithotripsy. I mean, they're supposed to be harder stones. If you've had it before and it fails, we won't do it. But actually, it can be useful in some select patients, and some stones are softer. I mentioned about early treatment, and I think this is important for this cohort of patients who are going to get a lifelong number of insults to their kidney from having stones. And of course, we should try and render them as stone-free as possible, but that isn't necessarily needed. And we have a number of patients who have stones in funny little locations in the kidney, and you can leave those, and actually they tend to just stay there. And it's probably something to do with flow and stasis as to why they form there in the first place. We personally believe there is an extended indication for ureteroscopy. Some people might say this is more reason to do PCNL and clear them, but actually for people who are going to have a lady, like I showed earlier, with all those stabs in her back, trying to offer ureteroscopy, maybe for slightly larger stones. And in the era of new high-power lasers, that's probably even more feasible. And we increasingly find that ECIRS, so combined ureteroscopy and PCNL, is particularly useful in trying to render these patients as stone-free as possible. Just to mention here, just the Hounsfield units, this is just a sort of clinical case, where we looked at our series of patients and with CT scans, and almost almost exclusively the hands-full units are under 800. These are probably mixed. We didn't necessarily have stone analysis to correlate with each one. So if you see a hands-full unit more than that, it's probably calcium containing. And this patient is an excellent example. She's got a single kidney, had this stone here, I've just shown 2 slices here. Hands-full units 700 here, and on the top of it there was hands-full units 1200. And when we did the PCNL, you find typical cystine stone here, and you reach the demarcation where you had a completely different type of stone. And so this was a cystine stone with a calcium phosphate cap sitting on top. And you could predict that beforehand just from looking at the CT and appropriately measuring the hands-full units. So let's just try and look at some of these issues that they face. And so to just go start with fragmentation of care. I talked about our clinic setup, of course, but it can still be fragmented due to the geographical issues that our patients face. So we give our nurse specialist contact details as the first point of contact via bleep or email, and they have access to our renal pharmacist. And it's currently the busiest email I see is to the renal pharmacist because they're always running out of their drug and can't get hold of it. We give them a dedicated email, cystinuria@GSTT, so they contact us, and myself or Kay will see that email and usually, hopefully, respond to it. And we do run a walk-in clinic, guys, for our own patients to walk in, and we really encourage our cystinuria patients to know that that facility is there. So if you're in the community, you're having a trouble, you're in and out of your own emergency department, can't get anywhere, just walk into our clinic and someone will see you and hopefully alert us. And this is the patient card that we started giving patients back in 2008. So they carry it in their wallet and give that, and can show that if they go to the emergency department and go, look, I am genuine, I do have a condition, please call this number if you want more information. Regarding lack of information, so our patients said, we want more, this is back in 2008, we want more patient information. It's often not very UK focused, and so we created a website. There is no budget for this, so this is me, I'm not an IT specialist, as you may realise. I have no training at all, but write a website, use free Google Sites software to do it. It costs me £10 a year to purchase a domain name. We asked our patients what they wanted, so they really constructed this, the list here of pages as to sort of really patient-orientated questions that they want answers to. And so this is our original website, which we refreshed about 5 years ago into a bit more of a modern-looking website. Has it been successful? I think so. We get a lot of good feedback from it, and it consistently gets about 300 hits a month, which I think is not bad for a sort of specialist patient information website like this. And is it just the UK that's looking at it? Well, no, actually. So yes, the UK is the most, but actually USA 25%, and the blue is countries that have accessed it. So almost every country in the world that has the internet has at some point accessed our cystinuria website. And I just put this comment, so I left this slide in just because of the one in orange. Actually, it amused me since we've got veterinary researchers here. They fielding questions like this, I've got a vet asking us if they can help them secure tiopronin for their 10-year-old Staffordshire Bull Terrier. We couldn't actually help them, unfortunately. Our patients wanted a forum aware that there are Facebook pages both in the US and the UK, but actually they wanted a dedicated forum, so we've set something up for them using this platform called Health Unlocked, which is a bit like Facebook but for health. And so we created this the page Cystinuria Support, which has been reasonably successful. We've now got nearly 240 members. I think it's a bit of a slow burner list. Some patients like it, some patients don't. But we've had some very, very interesting discussions on that, and they moderate it themselves. We get 2 patients to act as moderators. We've now had 6 national cystinuria patient days. The last was in Newcastle just in the last year. This is a picture, I think, from 2019. And we tried to do some innovative things for our patients. So this is one of our patients who's had multiple ureteroscopies in his life, and he's using a model here that we usually give to residents to practice doing flexible ureteroscopy with a model, so he can actually have a go and understand what we do of the procedure that he's had so many times himself. You'll be pleased to know, Dr. Penniston, that the most popular stand by a long way is always the dietitian stand. I've cropped out patients here, but always loads and loads of questions about diet and what can we do to help ourselves. This is from 2019. We had a fairly famous visitor from the US who came and joined us, and David, they still talk about your visit and how much they enjoyed it. And I'll let you explain later exactly what you're doing here, but this is the old operating theatre museum adjacent to Guy's, and this is an operating theatre from the 1800s with Professor Goldfarb lying ready for his operation, cutting for the stone. We've had some cookbooks. We've created 2 cookbooks. The first one here, Lose a Stone, in conjunction with the head chef from a local restaurant. and some funding from the guys in St Thomas's charity, and a follow-up book called Stones Through to Health. This is again done on a budget. Some of this photography was done by me in Borough Market or in Kay Thomas's garden. She cooked the food and I took pictures of it. And then it's educational, so our dietitian has gone through it and categorised it into low, medium or high for various different fat and salt contents, and given practical tips for our patients, which is what they want. So what can you do to help yourself? What can you do to reduce salt? And also dining out, that happens a lot, doesn't it? So what can you do? What can you eat when you go out that isn't terrible for you? These aren't just for our patients. We have made these freely available via our website in PDF form so they can be downloaded. And interestingly, 2 years ago, I was contacted by the person who runs the Romanian Cystine Uro web pages and asked if he could borrow the book and translate it into Romanian, which of course he said, feel free. So this is a Romanian translation of the first book, Lose a Stone. And interestingly, they went through and just read all the pictures. They obviously didn't like our pictures in it. We've had cookery classes for our patients, so we'll again a bit of charity funding, taken them to a professional restaurant in London where they get to cook and learn how to cook healthy recipes. Just again, this whole thing about trying to persuade patients that you can eat healthily and it can be enjoyable and fun. And my fun bit was actually eating all the food after the end of it. So just to sort of slowly wrap up, what about these issues here? So difficulty transitioning to adulthood. We have not succeeded in this, and it's been a bit of a disappointment and still work in progress. We had a medical student do a project on this. We want to get some web pages on this. We had a patient who was going to set up a sort of adolescent patient support network, and that never happened. So we haven't really managed to do this yet. It's a difficult, as you probably aware, it's a difficult group to try and get together. Pregnancy is always an issue and always a concern for these patients. So we did this survey in our patients and asked all our female patients about it. So this is just a survey, but up to a third think it's a barrier to pregnancy. And sadly, we have at least 2 patients in our clinic older patients now, who didn't have children because back in the day they were told they shouldn't have children because of their genetic condition. Up to a third have to stop medications because of their pregnancy, and about half felt that they'd formed stones in their pregnancy as a result of pregnancy and therefore needed treatment for it. And of course, everybody's concerned about their children. Absolutely everybody is concerned about, will my children get it? So what can we do in our clinic? Well, obviously we've got the setup in our clinic to have these conversations early with these patients. You know, one day you're going to want to get pregnant, please tell us, please try and plan it with us. We can make a plan for your medication, when you're going to stop it. Is there anything else we can do to help? Give them reassurance that we looked after, and that's often what patients want, is knowing that they've got a point of contact, and if I'm in trouble, you'll help me. And obviously we've had to manage patients with nephrostomies through pregnancy, etc. And just give them easy access to the clinic, offer them regular ultrasounds for that reassurance, and tell them we'll manage their stones afterwards. And we can do that quickly for you post-delivery. I'll comment about COVID. I think our patients suffered quite disproportionately in COVID. In the UK, there was an official shielding program which came with some financial remuneration, and kidney disease was one of those things that is shielded, but actually only 12% of our patients were told they should shield. We fielded loads of questions. Oh, should I be shielding? Have I got kidney disease? And you're like, well, that's a complicated question, isn't it? You can't answer that in a one-line email. A lot of them had difficulty getting their medication. A lot of them didn't want to come to London to come to clinic, didn't want to go on public transport. I think up to half felt that they had formed stones and didn't want to go to the emergency department at the time, if you remember what that was like. The only positive side was actually, because they were home a lot, they did find it easy to keep hydrated. Just a mention about guidelines and some of the research. Guidelines, not surprisingly, EAU and the AUA guidelines are fairly limited in such a rare sort of disease. But we're quite lucky now we have these 2 very specific guidelines, which I think are both made quite good, easy reading, and are complementary to each other. The one on the left, you'll recognise plenty of the names from the US, and a European equivalent, which sort of was happening almost in parallel at the same time that we were involved with. And that was in coordination with the European reference networks, which are Eurogen and ERCnet, which have a thematic area in Cystine Uro, and we're an active part of that. So we have regular webinars, and we have a webinar coming up, which we do across Europe to try and educate clinicians. And there's also an interesting multidisciplinary meeting that happens periodically, every 2 or 3 months, when actually this is across Europe, and clinicians can join in, bring their problem patients to that, and ask us for advice and on how to best manage their patients. And then finally, just for this talk, it was quite interesting putting together our research and the things that we have achieved, maybe things we could have achieved and should have done better on over the last 15 years or so. We're both full-time clinicians and both have significant management roles. And I've tried to interweave some of these things into the talk I've done so far. But just a few things that I didn't put in. This was a study a while ago now looking at the role of crystalluria and whether early morning urine or clinic urines predicted stone episodes, and we found that clinic urine did, early morning urines didn't, which may go against some other literature. This is looking at urinary amino acids and whether that was predictive. And we found that actually the other 3 amino acids, ornithine, arginine, and lysine, were better predictors than cystine. And that's presumably because cystine is in a solid form in stones, which is why in the US we don't have access to it, but you have your cystine capacity test to try and get around that barrier of the fact that a lot of cystine may be in solid form. We've now got a massive genetic pool, and this was published a while ago, so we now need to refresh this, because I think this was only about 40 patients when we published. We can now do it on over 250. We're reporting new mutations in cystinuria. And then 2 interesting projects that our medical students did. One was looking at do first-degree relatives share a similar phenotype, because you'd think they would have the similar genetics. And actually, as you probably see from these line graphs, actually they were wildly different, and so there really is very little correlation. And even we have one identical twin pair, and they have very, very different clinical pathway from their cystinuria. So there's something else, obviously, in life and nurture, it isn't all just genetics. And then this is our series of 20 heterozygote SLC7A9 heterozygotes. Looking at them, and 14 of them definitely have clinical cystinuria. So I'm trying to answer the question of autosomal recessive or autosomal dominant cystinuria. I put this in because I think in the guidelines it says you should always give vitamin B6 if you're giving penicillamine. That hasn't been our practice. This is again another medical student project who looked at all our patients, and only in one has there ever been any. We measured vitamin B6 when they come to clinic, and only one has ever had a level below the reference level, and they didn't have any clinical symptoms. And we don't routinely do this and just check it periodically. And I can put this in as a nod to you. We copied your work and just decided to test this in the UK population to look at the health-related quality of life using the Wisconsin Stone Quality of Life Score, and something not surprisingly showed that cystinuria patients have a worse health-related quality of life compared to other type of stone forms. So finally, a few reflections. The NHS gets a bad press. I don't know what you see over here. We've now got 7 million people on our waiting list and growing. But actually, it's amazing in enabling us to be able to do projects and things like this, and I'm not sure it's possible in other parts of the world. We set up a service and patients come to us. The NHS Constitution says patients can go where they want if they wish, and actually, clinicians are very, very happy to refer these patients. It's just off their hands, refer to Matt or Kay. And we've seen a real explosion of this after COVID, was I think with people who are just overwhelmed with waiting lists have just gone, oh, okay, I know what, I'll send you up to London to see us. It's come with a lot of frustrations. We haven't always had consistent nursing support, and I still don't think it was as good as they should be. We've never ever had a psychologist in clinic, and I think that we really do need that. The drugs are unbelievably frustrating, and I feel so sorry for our patients when we can't reliably give them good alkalization, and we can't reliably give them a good supply of chelating agent when they need it, and they really need to drive that themselves. And if they run out and expecting someone to contact them, that just isn't going to happen. And research, we could do so much better in research. We're about to hear Tom Chi talking about his experience with ALA. We tried really hard, Tom, to join your trial, as you know, but the barriers in the way of joining a transatlantic trial were too great, and then COVID happened. We were also due to join a randomised trial in France of a new alkalization treatment, and again, the barriers of doing that were too great. So in the future, we definitely want to sort out this transitioning, support for transitioning patients. That's really important, and that's where hopefully maybe a role of psychologists would come in as well. Needs to do more with our genetics. We now have an amazing 280-odd group of genotyped patients. We need to do more with that to try and understand the disease. And we need to work out how we scale up the clinic. We can't just do this twice a month anymore. So how do we try and put more clinics in the confines of our job plans and what we do. Thank you very much for listening. I present this really on behalf of myself and my colleague Kay Thomas, but actually it's also the wider team as well, our nephrology colleagues, dietitians, and our radiologists and our nurse. Thank you very much.